Hello everyone, you're watching sqadia.com and today we'll be discussing about now Reiter syndrome and reactive arthritis. Have you ever heard of Reiter syndrome? Probably yes. Now in this we'll discuss about general aspects in epidemiology of Reiter syndrome and reactive arthritis. What are the clinical features of these two diseases? There's although almost the same thing but slightly different than each other. And then what about the treatment and how we can differentiate between Reiter syndrome and reactive arthritis. So Reiter syndrome, it is classically a clinical triad of urethritis, that is the inflammation of urethra, arthritis, that is the joints which are involved, mainly of the lower limb, especially of the ankle and the foot area, and conjunctivitis, that is the inflammation of conjunctiva, occurring some weeks after either dysentery or genitourinary infection. This is kind of a usually when you dig out the history, there is either in if it is a young child, there's usually history of dysentery, or if it's an adult, it's usually history of some kind of a genitourinary infection few weeks back, 3 to 4 weeks back, and once that has resolved now on its own, but now then there's a new disease coming up resulting in urethritis, arthritis, and conjunctivitis, kind of a picture which is actually a triad of these three forms the Reiter syndrome. That was described by Hans Reiter in 1916. It occurs in 1 to 3% of all people who develop either non-specific urogenital infection or Shigella dysentery, especially common with the Shigella dysentery. In HLA-B27 positive, it is as high as 25%. Now, you know, there we have discussed in detail that HLA-B27 could be positive. We may be having a genetic susceptibility. In patients who are HLA-B27 positive, there is high propensity of these patients to develop Reiter syndrome after dysentery. So that is important as well, that it also has a genetic component. That is, not all those patients who have developed urethritis or dysentery will eventually develop Reiter syndrome, but those with even 25% of the all who have HLA-B27 positive usually have a chance of developing Reiter syndrome. Now coming to the general aspects, men are affected 10 times more than women. The usual age at onset is between 20 and 40 years, but children infected too, perhaps after an episode of diarrhea, which is mostly it is always the Shigella dysentery. Coming to the symptoms, the most common is arthritis, which is mainly involving the ankle and the foot, that is the conjunctivitis, and following the urethritis. Then what are the causes and pathogenesis? The causes, as I told you, is most commonly it develops after either a urethritis, that is in any microbe which is causing urethral infection or inflammation, or it is causing Shigella dysentery. So most common is genetic predisposition and close association with HLA-B27 gene. That is, those who have HLA-B27 gene in their genome, 25% of them are susceptible of having Reiter syndrome after infection. The bowel or genitourinary infection acting as the trigger, and usually the gut pathogens include Shigella flexneri, which is most common cause of Shigella dysentery, Salmonella, and Campylobacter species, and Yersinia enterocolitica. These are all the gut pathogens which may be cause of the dysentery and later on may be causing the Reiter syndrome. Coming to it, has actually two phases. There is an acute phase and there is a chronic phase of the Reiter syndrome. Acute phase includes asymmetrical inflammatory arthritis of lower limb joints, especially the knee, ankle, tarsal, and toe joints, and that are common in the tarsal and toe joints, mainly around the ankle and the foot area. Tensioachilles tenderness and plantar fasciitis is also common occurrence, so these are associated problems. Sometimes when these patients present, the initial diagnosis is plantar fasciitis, but when you dig out the history in detail, there is maybe associated Reiter syndrome which is going on. Patient may complain of backache even in early stage. It could be whatever the joint is involved that will be showing the symptom. Most common it is in acute phase is the lower limb, especially at the ankle, the foot, but it could be high in the knee, hip, even the lower back area as well. Now, once acute phase is going on, there's associated conjunctivitis along with arthritis, and then urethritis and bowel infections are often mild and easily correctable. That is, you can usually, if there is always a history of there was some degree of either urethritis or dysentery which was treated, and now the patient is again complaining of joint pains, and there is spotted discharge in the eyes similarly, and then there is an burning maturation as well. Less frequent but equally characteristic features include vesicular pustular dermatitis of the feet, which is being shown in this picture, balanitis, and mild buccal ulceration. Now, the more clear picture is this is showing a chronic phase. Once the acute phase is over, this leads to a chronic kind of phase. Now, chronic phase will also include all of these three things, but the time duration would be such that probably the parents would not really know, or may have forgot that there was some kind of a dysentery or arthritis initially. More characteristic of spondyloarthropathy means the joint pain and joint problems are more predominant. Over half of the patients with Reiter syndrome complain of mild recurrent episodes of polyarthritis. That now the initial trigger was done and it's got corrected. The acute phase is also over, but there, without any trigger, the patient would be complaining of polyarthralgia, multiple joint pains. Uveitis is common, which is usually associated with chronic phase of the Reiter syndrome. Now, once you know it, then the investigations on history, there would be definitely either history of urethritis, or there would be history of some kind of a bowel dysentery. You know, the patient is complaining of multiple joint pains and conjunctivitis and urethritis. Now, then you should be suspecting Reiter syndrome. How would we investigate such disease? Now it comes to investigation that includes mainly it's X-rays, which usually are normal. For example, if you see it over here, then comes to the differential diagnosis. Ankylosing spondylitis is one of the differential diagnosis. Gout, gonococcal arthritis, enteropathic arthritis, and these are one of this. Why usually gout is in? Because mostly it's the foot, and sometimes the first metatarsal which is actually inflamed. So most likely the first differential which comes to mind is actually gout, and then as it has a propensity for HLA-B27 genes as well, so most likely it could be ankylosing spondylitis when this kind of a Reiter syndrome presents with low back pain only. And other includes the gonococcal arthritis. Yes, we should be keeping that in mind as well, especially in sexually active individuals. And then coming to the last is enteropathic arthritis as well, because usually there is a history of bowel dysentery, so this could also be kept in the differentials. Coming to the treatment, initial treatment is aimed at ensuring infectious organism responsible which has been cleared. Particularly important was STDs such as chlamydia trachomatis infection. Symptomatic treatment could include the use of analgesia, and that is the NSAIDs. So that the DMARDs used in the treatment of rheumatoid arthritis can also be used over here as well, as it is also the disease modifying drugs for other spondyloarthropathies as well. Topical steroids may be used for uveitis only, and that's it. And thank you very much. Keep watching sqadia.com.